We've already heard at previous meetings a fair bit about the effectiveness of Daratumumab, which now has several phase 3 trials in the relapse setting, showing it to be a very promising agent. I think one of the main things that was emphasized here about its effectiveness was the depth of the responses that it's able to produce. And the high rates of minimal residual disease negativity that can be seen with Daratumumab in combination with other therapies. It really seems with the CD38 anti-CD38 antibodies that their potential is really most fully realized in combination with other drugs. And that's particularly seen in the depth of response that's seen using more sophisticated techniques to look at small amounts of residual disease.
Yeah, so you remember Dr. Dimopoulos talked about Castor and Pollux. Just to remember, these are the combination studies in relapse refractory myeloma. That they were the first studies looking at MRD in a prospective manner, using next generation sequencing, and using the cutoff of 10 to the minus 5 as an MRD. The Revlimid dexamethasone arm had a 5% MRD negativity, whereas the combination arm with Daratumumab had a 25% MRD negativity, attesting to the efficacy of this drug. And the MRD was a predictor of PFS, which is also, I think, very logical.
Yes, it does seem that the patients who achieve MRD negativity do considerably better than those who don't. Though, of course, MRD is a moving target, as we find better and better tools to detect small amounts of residual disease.
So, what do you think would be the relevance for the our Canadian colleagues in terms of MRD testing and reality in our country?
Well, I think above all for now, I think its use is primarily in clinical trials, where it can be an excellent surrogate measure for the effectiveness of a given agent, as it has been with Daratumumab. How it can be used in daily clinical practice to guide our treatment decisions still remains to be proven, but we can expect it to have a role in the future.